Okay, so motor systems and these great summary charts. So the schematic on the bottom here is showing you a cross-sectional view of a spinal cord. And on the left side, it has pathways in blue, which are showing you the major sensory pathways, which we're just about to do. And in red on the right are the major motor pathways. Now please remember the fact that there's a lateral cortical spinal on the right and of course one on the left. But if you look at the positioning of lateral cortical spinal, you can see how that pathway is laterally situated, and right next to it is its helper pathway, which you don't really have to worry about, which is rubrospinal. So it's collectively, those are the lateral motor pathways, and the predominant one in there is lateral cortical spinal. The medial motor pathways comprise of anterior cortical spinal, and there it is right down here. And again, it's bilaterally situated, and you can see it gets its name by its anterior positioning within the cord. And its helper pathways are things like this vestibulotract, vestibulospinal tracts. Now, vestibular, if you think about vestibular, like that's about the vestibular apparatus, right? So balance, positioning in space. And the vestibular apparatus and vestibulospinal tract is really important for the positioning of the head and neck. And again, it's this idea of balance and your sense of being, your posture, uprightness, right, all the time. So, and these other pathways help out as well. Again, with posture, this reticulospinal and tectospinal is coordinating head and eye movements. Now, when it comes to major deficits and things that are going to go wrong in individuals, it's clear the fact that the major pathway I've talked about is this one here, lateral cortical spinal. So it's these 5 things here that are absolutely important that you understand. That you be able to understand the pathway, where the axons go, where they terminate, what the function of the pathway is, etc. That you understand that there are other pathways that are about posture and gait and uprightness, and that's anterior corticospinal. With some other pathways, it is important, but it's certainly not as clinically relevant as lateral corticospinal is. So, if we look then at this individual, so here we actually have our dots representing the cell bodies, our lines representing their axons, and we can clearly see where the upper and lower motor neurons are. The upper motor neurons are located in the cortex, and the lower motor neurons in the spinal cord, or in this case, as well as the brainstem. We have the left and the right side of our patient, the right and left side of the brain, and then we have this big red thing here, which is showing like an infarct, right? You've cut off the oxygen supply, a major stroke. Now, one of the concepts that I think is important for you to recognize is the fact that you don't actually have to kill neurons for them not to work. If you cut off the blood supply to their axons, the neuron no longer can transmit the electrical signals that actually are generated in the cell body and then they fly down the axon. So if this is not represented, this could represent trauma, but more often than not, what it's representing is some sort of infarction. You've cut off the blood supply, which really means the cell bodies are still intact, the axons are intact, it's just they're not functioning because they need oxygen and glucose as well to work. So if we look at the infarct, it's a really big area, and it's probably within that internal capsule as the axons descend through the brain en route to the brainstem and then the spinal cord. But we've got a large lesion here. And the large lesion is encompassing what? All of our descending corticospinal and corticobulbar axons. Corticospinal meaning starting in the cortex, terminating in the spinal cord. Corticobulbar meaning starting in the cortex and terminating in the brainstem, specifically for motor function of the head. All right. So, what about our homunculus? What can we say about the homunculus? So we've got 3 neurons represented. One is very medial, one is more on the lateral surface superior, and one is on the lateral surface inferior. And if you think about the homunculus again, right, So the leg and the foot, as we come around here, the body and the hand and the face. So we've got the foot, hand, and the face represented here as the cortical neurons that give rise to inputs affecting motor neurons controlling everything of the face, and other motor neurons affecting the upper and the lower limb. All right, so here we have an individual. Let's say you've already presented with the individual. You know that they have a unilateral face, arm, and leg weakness. So how would you be able to explain the fact that you've got this tremendous degree of stroke or infarction that's affecting the complete one side of the body? Well, to do that, you've got to find a place where all these axons are traveling together. This lesion could definitely have been of the cortex, a huge area of the cortex, but it's interesting that this patient has no cortical deficits, higher cortical function. So there's no problem with language processing, so the understanding of language. And we'll see how that's actually in a different part of the brain. So it clearly is only affecting motor function. So where would all these motor functions be together that you could have this one specific lesion to knock everybody out? And probably that's occurring in the internal capsule. So then you get the radiologist report saying, yes, indeed, there's a major infarct in the internal capsule, and that's why the patient presents this way. Importantly, there are no sensory deficits. So this is completely motor. So we know we have to be affecting the motor neurons. And we know it's affecting face, upper arm, and lower arm. So we need to be affecting all of the neurons having to do with each of those modalities. Now, is this an upper or a lower motor neuron injury? Which of the two populations are affected? Upper or lower? And it's upper, right? So the lower motor neurons are quite intact, physically, functionally. The problem is they're not receiving the voluntary signals to do things. So you would approach this patient, you would say, move your left hand, no problem whatsoever, and an inability to move their right hand. It would be complete paralysis on the right side. So we know that it's unilateral, and it has to be on the opposite side of the lesion, right? So it has to be, if the right side is affected, it has to be on the left side of the brain. What else can we say about this? It's likely a vascular lesion, as it says, like an infarct of the internal capsule. That's great. And as much as we actually have this paralysis of the limbs, what else do we have? We have this dysarthria. And dysarthria is a disturbance in your ability to speak. And it's not that you don't know the words to say, and it's not that you fail to comprehend what's being asked of you, but if you think that the neurons that drive all your formulation of speech are right about here, right? Thinking back to the homunculus. So we've got motor neurons innervating the mouth, motor neurons innervating the tongue, the pharynx and the larynx, then clearly these signals are being disrupted and the patient cannot speak properly. So you have this idea of dysarthria appearing as well. So the things that tell you that this is completely motor is the fact that there are no sensory deficits. The thing that tells you that it's completely motor and not much else is affected is there are no other cortical deficits like language processing. So if you ask the patient a question, they don't understand. That's language processing. Or they understand the question, they can't formulate the words. They don't know the words. That's another problem. Here, it's just articulating the sounds to make the words comprehended, to be comprehended. So, what else can we say? So we've actually disrupted all the axons, their functioning of the upper motor neurons as they're descending somewhere through the brain en route to the brain stem. And of course, the radiological report would actually describe exactly where that infarct probably has occurred. So does that one look reasonable? You get the idea that everybody's being affected. So you'll see strokes like this, absolutely, where the patient has complete hemiplegia on the one side, right? Their face is drooping, right, because it's not working properly, their inability to speak properly, right? But as much as you'll see these massive strokes, you'll see much smaller ones. And the smaller strokes, clearly, when you look at the deficit now, and it's only affecting the upper arm and the face, where could we find a place where the stroke is going to have a more specific result on the body? And that could be in the internal capsule. That would have to be a really small lesion. But chances are the stroke may occur in a very specific area of the cortex. And in this case, it's the sort of the inferior part here of our motor cortex, primary motor cortex, which really means that the neurons having to do with the foot, right, the leg, the knee, right, the thigh, the hip, the trunk, the shoulder, they're all spared. And yet we come here to the arm and the hand and the face, they're the ones now the blood supply is cut off. Cut off the blood supply to the cell body of neurons, chances are at the core of the stroke, those cells are going to die. And so this is actually a very, very bad outcome because chances are there's going to be a lot of neuronal death going on here. So if we think about it, we've really lost those neurons. But what is the consequence to the patient? So now, because you've actually cut off the blood supply to a very precise part of the primary motor cortex, you're only affecting a specific population. And this is where your knowledge of the homunculus is really important. Because now when you look at the scan, you're going to see the fact that the infarct is in a much smaller area of the cortex. And you can link that directly with how the patient presents. Now we still have this contralateral deficit. Absolutely, it's contralateral. The lesion on the one side, the effect on the opposite side. Okay, we get that. But it's not universal, right? It's not from the top of the head all the way to the foot. Rather, what we actually have is very specific weakness to the cortical bulbar pathways, cortex, the brainstem for the face, and upper corticospinal. That is, for the cortical neurons to the upper limb, affecting the motor neurons. But these, for the leg, are intact on that affected side. So that suggests the fact that the site of the lesion is much more circumscribed. It's much smaller. Now, one of the problems that can occur here is the fact that now, because we are in the cortex, the size of the lesion actually can be very small or, in fact, a little bit bigger. And these lesions that are a bit bigger, especially in the dominant hemisphere, can actually give rise to a condition called Broca's aphasia. And that's actually where you have this decreased fluency in spontaneous speech. And so we'll talk about that in another time. But the idea here is the fact that it's not so much now you have the dysarthria, which you can't formulate the words, but now you don't know the words, right? You can't get the words out because you don't know them. You're not able to get around that fluency of speech. So there's another part of the brain that's all about us formulating words, not just merely the mechanics, but words that people can understand. So the important thing here is for this lateral corticospinal pathway is for you to think about that the lesions can be very large to affect the upper limb, or very, very, very small, rather, just to affect the upper limb, or very large to affect the contralateral side of the body. And that the inclusion of cortico-bulbar pathways clearly means the fact that you've affected that part of the cortex where the motor neurons are, the upper motor neurons that drive those bulbar neurons in the brainstem. So what would those bulbar neurons be? What cranial nuclei are we talking about? Now, this is cranial nerves now, right? So the cranial nerves we'll be talking about are definitely things like facial. So you'd have a facial paralysis on the one side. And if we're talking about the pharynx and the larynx, right, there's a motor component, the glossopharyngeus, small but still important motor component. But clearly vagus, right, for the laryngeal muscles and the pharyngeal muscles. And hypoglossal, right, the movement of the tongue. So those are the nuclei that you're going to find in the brainstem that are being controlled by these cortical neurons up there. So within this collection here, we can think of facial, glossopharyngeus, vagus, and hypoglossal. You notice something curious about these two schematics, about the body, especially on the affected side, if we go back and forth. So just look on the affected side. There's something curious about the body. Yeah, it's the forehead. I don't know what it is about the human forehead. It's a bit odd, but the human forehead actually receives bilateral inputs. So the left cortex innervates both left and right motor neurons, allowing you to furrow your forehead. Why? I don't know. But it takes, so unilateral lesions do not result in a denervation of the forehead. I don't know why, but it's just one of those things. So forehead actually has bilateral input. So if you think about the neurons that are coming down here to innervate neurons for the forehead, they would bifurcate and go both left and right. That's just one of those curious things. Okay, so this evening, when you go back and look at this stuff, definitely think about lateral cortical spinal. Get in your mind about where these neurons originate, where they terminate, where the axonal pathway decussate is. And definitely get now a very good idea about this homunculus. Because once you learn the homunculus from motor, it's almost identical for sensory, which we're just about to do. So, and it's absolutely critical that you understand this because of this idea of regionalization. This part of the cortex is for the lower limb. This part of the cortex is for upper limb. This part of the motor cortex is for face. It does not change. It's the same in all of us. So when you presented with a patient who has a very tiny infarct in this one little part right here, and they can't move the contralateral hand, you'll understand that that's a perfect match. Right? Good. Yes? Can be. I mean, all these are going to be different, right? Depending on where, but go ahead, yes? Oh, so it all depends on what branch of the middle cerebral. So if you actually think about the middle cerebral artery, it starts very deep in the brain, actually courses through the brain to give off those, Dr. Cooper mentioned, lenticulostriate arteries. Okay. And then when it comes out superficially, so really, it's the middle cerebral artery, when it comes out here superficially, that would be occluded. Right? And as it's going over the surface of the cortex here. Absolutely. And then an occlusion deeper in here would just affect that particular branches of the artery that are supplying the internal capsule. So you definitely can have these occlusions being cutting off blood supply to a huge part of the brain, or to very, very, very small parts of the brain that rise to specific lesions. Absolutely. Okay, and that was just some terms that you should all look over because they have to do with your clinical training. All right, so let's go on to sensory, and let's do some comparisons between sensory and motor systems. All right, so as much as I've given you only one major motor pathway, I'm only going to give you two major sensory pathways. Okay? Because it's important that if that's what you know, if that's what you take with you when you get to clinic, then you're well ahead of the game. Because these three pathways are the predominant ones that you're going to see affected. All right? So your understanding of the anatomy of these three pathways is going to help with you recognizing the clinical presentation of patients and understanding why the patients are presenting this way and linking it with the anatomy. All right? So, not so bad. Just three pathways. Right? So, one major motor pathway, two major sensory pathways. And again, what we'll end up doing is trying to provide a comparison between these two so we understand how they're similar and how they're different. Okay, so here they are here. Here are our three pathways, beautifully put in this one little chart down here. lateral cortical spinal. The next one, which is a sensory pathway, is this posterior column medial lemniscus, and the other one is referred to anterolateral. And look at the function of these things. I mean, it distills it down so basically, right? Lateral cortical spinal, motor. Voluntary motor to the important parts of your body, like your hand, your limbs, right? And then posterior column medial lemniscus is all about joint positioning, fine touch. Not so much vibration. You're going to test vibration. People aren't going to come in and complain about an absence of perceiving vibration. But certainly an inability to perceive fine touch or a joint positioning, not knowing where their limbs are in space, right? And then the anterolateral pathway is all about the really important things like pain and temperature. So here we have a very clear parcellation of two sets of functions. Joint positioning, fine touch, pain and temperature, crude touch. Two pathways that need to do two completely different things. And if you think about it intuitively, what are these pathways doing? They are bringing sensory information from the periphery of your body, right, to your brain, where you can understand, you can explain exactly where that information is coming from. So with your eyes closed, you know that if someone's touching your left hand versus your right foot, you can describe that. How are you consciously aware of the origin of this sensory information? That's what this is all about. So I mentioned the other day about how if we think about these bits of sensory information from the periphery getting back into the central nervous system, the first step is transducing a signal peripherally that will then be brought back into the central nervous system. To do that, we have specialized end organs that pick up this information. Within skeletal muscle, and this is important, skeletal muscle, not smooth, not cardiac, there are these things called muscle spindles. And what they're doing is sensing the stretch. So if you think about picking something up that's very heavy, right? As you're lifting it, your muscles are being stretched. And within the skeletal muscle are these sensors that are detecting how much stretch is going on. And as much as you have stretch receptors in skeletal muscle, you have tension receptors in your tendons, because you know the tendons are helping you in that process as well. And these are called the Golgi tendon organs. And collectively, they come under the heading of proprioception. What are my limbs doing from a sensory point of view? Mechanically, what are they doing? For the fine touch, which us human beings really like to use our fingers, right? Especially for fine touch. We have these things called Meissner's corpuscles. And Meissner's corpuscles allow us to perceive very, very fine differences in materials put in our hands. We have other receptors like Pacinian, Ruffini, things like that to help with other things. Not so important, right? But then for pain and temperature, we have these bare nerve endings in our skin, which are picking up these sensations. Now, the way I like to think about this stuff is, remember I told you about the size of the axon and the presence or absence of myelin determines how fast the signal gets back to the nervous system. So the big ones, the big axons, are the muscle spindle axons, the Golgi tendon axons, or proprioception. Why would they be faster than pain and temperature? Well, the analogy I always like to give, is a primate swinging through the trees, right? Grabs onto a limb, and on that limb is a nasty thorn that actually pierces the hand. What's more important? Recognizing the grip of the hand on the limb, or going sort of ouch, that kind of hurts. So the proprioceptive information is much more important than pain and temperature. Pain and temperature can wait. Proprioception is like of the moment, right? So that information's got to get back to the nervous system faster than pain and temperature. So these axons are bigger and they're myelinated. The pain and temperature ones are small and tend to be poorly myelinated or not myelinated at all. So we want to get these things back. So of all these specialized receptors that are picking up this information, Muscle spindles, Golgi tendon organs, absolutely important. Meissner's corpuscles for fine discriminatory touch, very important. And the concept of bare nerve endings for pain and temperature. Great. So, as much as the motor pathway was 2 neurons, our sensory pathway is 3 neurons. Where are our 3 neurons and what are they doing? So, if we think about the first pathway, which is actually going to be our posterior column medial lemniscus, it's a 2-part name based on how the axons present themselves in the central nervous system. So that's just a preamble about how we get these names. Posterior column, medial lemniscus. What's the pathway about? We'll go back to the chart. Vibration, proprioception, fine discriminatory touch, right? So what are we needing? So this is representing a specialized end organ, receptor out there to pick up that kind of information. That end organ in your skin, your skeletal muscle, in your tendons, is connected to that peripheral process of our first neuron, which are those pseudo-unipolar neurons that reside within the dorsal root ganglion. All neurons within dorsal root ganglion are pseudo-unipolar. All pseudo-unipolar neurons are sensory, so it's a really easy thing to remember. If you think about it, these neurons are bringing back this information from the periphery, and they have to get it where? We have to get it somehow into the central nervous system. So these neurons have these large axons that extend quite long distances peripherally, and then they have much shorter axons that extend into the central nervous system. And it's within the central nervous system that they're sharing that information. Now, these proprioceptive neurons actually have tremendously long axons, both peripherally and centrally. So the first neuron, its cell body is located in the dorsal root ganglion. And as we can see here, it's got to be on the same side as where the information is coming from. That just makes sense. Now, what does the axon do once it enters into the spinal cord? So, imagine light touch from your big toe. All right? So, your big left toe, right? So that axon is tremendously long, right? As it comes from your foot up the back of your leg, right? Into the back here, finding its dorsal root ganglion somewhere about here, and then its axon enters into the central nervous system. Where is the second neuron? The second neuron is not until we get all the way to the brainstem. At this level, referred to as the medulla. So there is our second neuron right there. And if you look at it, the information is still ipsilateral. It's still on the same side. That second neuron, its axon actually does what? It crosses the midline. So our proprioceptive information now from the right side of the body is ascending in the left side of the brainstem. Where is the third neuron? The third neuron is in a structure called the thalamus. And specifically, the thalamus is composed of a bunch of subnuclei, and it's got a very long, unfortunate name, which is the ventral posterior lateral thalamic nucleus. So our proprioceptive information ascends to the brainstem, ascends all the way to the thalamus, which is this deep structure in the diencephalon. And then now our third thalamic neuron projects onto the somatosensory cortex, where you have what? You've got that homunculus, where you now know that with your eyes closed, that your left big toe is being touched. Not your right, not your hand. All right? You can very precisely describe exactly what's being touched on your body. That fine, discriminative touch. Okay, so let's go back overall. So those are the three players. We've got a dorsal root ganglion neuron, we've got a neuron in the brainstem, and we've got a thalamic neuron. 1, 2, 3. If you look at it, it's the second neuron whose axon crosses the midline. Not the first, not the third, the second. So, how do we get this name, this posterior column medial lemniscus? Well, as these primary axons from our first neuron enter into the spinal cord, they ascend. And if we think about how the dorsal half of the spinal cord is all about sensory, these are sensory pathways, that makes sense. And these are referred to as the dorsal or posterior columns. These are huge myelinated axons that ascend all the way through the spinal cord. Now, because we're getting proprioceptive information from the entire body, the nervous system needs to begin to segregate things out. And it does so, first of all, by figuring out the upper and lower half of your trunk. So you actually get these two fasciculi. There's a gracilis and a cuneatus. The gracilis is the lower half of your body, and cuneatus is the upper half of your body. And so right now we're bringing in that proprioceptive information. It's still the first neuron, the axons of the first neuron, and they're ascending all the way to the brainstem, specifically at the level of the medulla. And fortunately enough, the names are exactly the same. Within the medulla, we find two nuclei. There's the cuneatus and the gracilis. And fortunately enough, it says nucleus gracilis pathway from the lower part of the body, nucleus cuneatus pathway from the upper part of the body. So again, remember that these schematics are only showing what's happening on one side, right? We can flip it around and do the other as well. These axons, as they cross, the second order axons, as they cross from one side to the other, form the structure called the internal arcuate fibers. And they then ascend all the way to the thalamic nucleus. So we get the first part of the name, this posterior columns, these huge bundles of myelinated axons in the dorsal aspect of the spinal cord, consisting of proprioceptive information coming from the lower half of the body and the upper half of the body. And the information is still on the same side. These second order axons, as they move through the brainstem, tend to take on various shapes. And it almost looks like a ribbon. And that's where we get the term medial lemniscus from. It's kind of this shape, this ribbony kind of structure that has a medial location to it. And we actually get this name, the medial lemniscus. So that describes the pathway. Dorsal column, medial lemniscus. Then we get to the thalamus, and thalamus must have lots of different nuclei in it to have something called the ventral posterior lateral thalamic nucleus. And fortunately enough, I'm only going to expect you to know 4 thalamic nuclei. And this is the first one, ventral posterior lateral. So if you think about it, this ventral posterior lateral nucleus is doing what? It's receiving all proprioceptive information from the contralateral side of the body. That thalamic nucleus is receiving that proprioceptive, fine touch, vibration information from the contralateral side of the body. But it must have it all figured out, right? Because then those thalamic neurons fan out to innervate the cortex, and the cortex can make very precise determinations as to where that information is coming from in your body. And that's all based on the homunculus. It should be, I hope. Where's the homunculus? Oh, well, go back to your homunculus on the motor one. It's exactly so that it's represented in the blue. So, I know, it's crazy, right? Big pathway. So what are the major parts of this pathway? One thing, 3 neurons. The first neuron is peripheral. It's in that dorsal root ganglia, but its axon comes into the central nervous system. Where do we find the second neuron? In the brainstem. Specifically in these 2 nuclei called cuneatus and gracilis, which match up to these pathways here for the upper and lower parts of the trunk. It's the second neuron's axon that crosses the midline. Remember that this information, the important information, crosses the midline. Lateral cortical spinal cross the midline. These important sensory pathways cross the midline. It's not the first neuron, it's not the third neuron. But you have to think about this as a continuum of information. The first one talks to second, second talks to third, third talks to the cortex. And if you think about the continuum of the information, it goes from one side over to the other. Those brainstem nucleus cuneatus and nucleus gracilis neurons innervate thalamic neurons, which then project their axons onto that primary somatosensory cortex, where you become now consciously aware of what's going on. So, think about how instantaneous that would be. So if you had your eyes shut and you had your hands out and someone were to just touch your small finger on your left hand, right? You'd see almost instantaneously. You'd be able to describe it. And think about the information, how it's traveling through this long axon peripherally, this incredibly long axon in the spinal cord, going to the brainstem, relaying up to the thalamus, and from the thalamus onto that very precise part of the cortex where you can distinguish even among your fingers and the parts of your finger on your one hand. Right? Tremendous degree of specificity for that very light, discriminative touch. So, nicely, there are lots of, again, like the autonomic nervous system between sympathetic and parasympathetics, there's a lot of similarities, and yet there must be some differences between these two major sensory pathways. So, our other pathway is anterolateral pathway. It too has 3 neurons. Guess what? The first neuron is peripheral, and the other 2 neurons are central. In fact, the other neuron, the thalamic, is actually the exact same part of the thalamus. That's very cool. So, but it's got to be different. So how is it different first and foremost? It's got to be different by these receptive endings out there in the periphery. What type of information are you getting? And there has to be a big difference between proprioceptive information like touch, right? Very important, versus pain and temperature or crude touch. So that's the first important distinction about these two pathways. But yet, it's a neuron within the dorsal root ganglion that picks it up. Clearly, it's got to be a different population of these neurons, but nonetheless, they reside in the same dorsal root ganglion. The axon comes into the spinal cord. And now, rather than the axon traveling all the way up to the brainstem, it actually finds a neuron in the spinal cord at or a little above, a little below that same level. And these neurons are found in the dorsal horn of the spinal cord. Dorsal again, all about sensory. This is sensory. What a perfect place for it to be. This second neuron found in the dorsal horn of the spinal cord, its axon does what? Crosses the midline. That's something the two pathways have in common. The information goes from one side to the other by the second neuron in the pathway. So this first neuron brings in the information, forms a synaptic contact with the second neuron, shares that information, and its axon crosses the midline and ascends in the spinal cord where it has this anterolateral positioning. Anterolateral, hence its name. It then ascends the brainstem and makes a few contacts here and there, but ultimately to innervate those ventral, posterior, lateral thalamic neurons again. That's something in common. Of all the nuclei that must be in the thalamus, this phrase is exactly the same between these two pathways, ventral, posterior, lateral, which means now that all sensory information, pain and temperature, crude touch, light touch, proprioception, is all being funneled into that one thalamic nucleus from the contralateral side of the body. And yet, you are consciously aware of the difference between something painfully hot put into your left hand and that hot object being incredibly heavy, right? So you can distinguish between the fact that the object is heavy, the object is hot, but it's in the palm of my left hand. And so this is clearly what this pathway is all about. These two pathways are to bring in the different types of information and for you to be able to be consciously aware of where it's coming from. So, 3 neurons in the chain. The first neuron's in the dorsal root ganglion. The second neuron is the one whose axon crosses the midline. The third, for these two pathways, is exactly the same. Ventral, posterior lateral thalamic nucleus. And then they all sort of fan out to go to the cortex, so you become aware of something in your foot, which would be this part of the cortex here. Everybody watching for a second? So it's like you were talking about painful information from your foot, proprioceptive information from your foot going to this part of the cortex. Your hand would be this part of the cortex, and the face, which we haven't done yet, would be this part of the cortex, because this is from the neck down. If you think about what we're talking about, this is information coming from the spinal cord. And if it's the spinal cord, it's got to be from the neck down. It has nothing yet to do with the face. So, this evening, look over these two pathways, ask yourself what's similar, what's different about them, and try to piece it together. The nervous system is a remarkable, structure. And when you look at things about this organization, you just, kind of have to marvel about how these things get laid down developmentally. But it almost makes such intuitive sense to do it this way, right? So rather than all your axons being, mixed up in there, all higgledy-piggledy with each other, right? That would make no sense whatsoever. Rather, both sets of axons, the ones associated with the dorsal columns over here and your anterolateral systems here, are incredibly segregated. That is, the axons having to do with the leg are all traveling together, the ones with the trunk are all traveling together, the arm and the neck, and that's where both the pain and temperature pathway and your proprioceptive pathway. Clearly, this has to be a cervical level of the spinal cord, because we actually have our fasciculus cuneatus here, which is bringing information from the upper part of the body, and there's our fasciculus gracilis from the lower part of the body. So leg, lower trunk, upper trunk, arm, and finally the occiput, the back of the head. So here we have our two sensory pathways, and it is important to recognize their location within the spinal cord. Here we have them in the dorsal columns here. This is bringing up information to the body, right, about proprioception and fine touch. And here we have pain and temperature. Now, look at this schematic, and there's an important question here. The information we find in these axons, okay, think about it now just for a moment. Here's the question. The information I find in these axons, is this on the ipsilateral or contralateral side of the body? The sensory information for proprioception, right, comes in, and those axons ascend without making any synaptic contact yet to the brainstem. So clearly, the dorsal columns are carrying information from the same side of the body. You get that? In it comes, and the axons ascend. Pain and temperature, the information comes in, finds a neuron in the dorsal horn here. That axon then crosses the midline and joins the anterior cortical spinal, anterolateral pathway. Which means that when we look at the anterolateral pathways, it's ascending contralateral information. This is important. So when we look at this cross-sectional view of the spinal cord, the proprioceptive information is still ipsilateral, but the pain and temperature information is contralateral. Proprioceptive information is ipsilateral, and the pain and temperature is contralateral. And that's, when you look at that again this evening, and you go back to these two schematics, you'll see that that's exactly what's going on, that the pain and temperature information coming into the spinal cord finds the second neuron at this level, its axon crosses the midline, and is ascending. If you think that's, if you go all the way down to the lower end of the spinal cord, so painful information coming from your foot, right? That foot information of pain is traveling on the opposite side of the spinal cord all the way up, right? Why is that important? Because it's important that you recognize how these pathways are organized. Because you will interact with individuals who have a spinal cord injury, and they'll present in a very specific way. And you need to understand why they have ipsilateral presentation for proprioception, but yet a contralateral presentation for pain and temperature. And that's about these axons and where they cross the midline. Now, as much as we have the ventral, posterior, lateral receiving all these inputs from pain and temperature and medial meniscus information, we have a ventral, posterior, medial that's receiving all the information from the head. And look at the word there. Look at that one word that is from the inputs, trigeminal. So we know that the trigeminal nerve, cranial nerve number 5, is responsible for all that pain and temperature, proprioceptive information, vibration, two-point discriminant touch, all that stuff from the head. And so even if we just use the word trigeminal, we can ask that we understand the fact this must be coming from the head. Trigeminal is a cranial nerve, and that information, just like the information from the body, is being funneled into a specific thalamic nucleus, and that is the ventral posterior medial. So only 2 thalamic nuclei so far. Ventral posterior lateral from the neck down, ventral posterior lateral medial from the neck up. Right, so back to our cortex. So we can see our primary motor cortex in red, voluntary activity, and now we have our primary somatosensory cortex behind this central sulcus in blue, and it has the unfortunate designation of 3-1-2. Don't ask me why Brodmann named it this way. That's just the way it is. But again, the homunculus is very much similar between the two of them, right? So lower limb, upper limb, face. And again, the face takes up the lion's share, and the upper limb take the lion's share of the cortical material, where you actually need to figure out the proprioceptive or the pain localization of information. Okay, so I'm stopping here because tomorrow morning we're going to look at these lesions and ask ourselves why they look like this. We're going to briefly talk about the sensory systems for the head. And then, so just if you want to make sure you have the right notes for tomorrow. So tomorrow will be, after we do finish up those pathways, tomorrow is going to be brainstem and brainstem, cortex, and oops, wrong person. Sorry. It's going to be brainstem, lecture number 10, cerebral number 11, and we'll probably throw in higher cortical function then, try to get that done, and maybe even a bit of limbic, try to get those all done, which then would leave us with our motor systems and vision for the last day. Not so bad. So that will be for tomorrow, finishing up this sensory, that's number 9, brainstem 10, cerebral 11, higher cortical 15, limbic 16. Okay? Now, let me turn this off.